Hello students, today we will discuss a small swelling as a case discussion, how they present with, and it is very common condition which we come across as a day-to-day surgical practice. A 40-year-old female presents with swelling in the scalp of 3 months duration, which is slowly progressive with mild pain and bleeding on touch. 3 months duration, short duration, bleeds on touch, incidence onset and mild pain. See that? This is how exactly it looks. Color, everything you can look at that. So what are the differential diagnosis for this swelling? I will explain further. It is in the scalp, single swelling, 3 months duration. It is surface color is red, well localized. It is mildly tender, mobile in both directions. No neck lymph nodes are palpable. So what is the differential diagnosis you have to think of? Then I will go on telling the differential diagnosis. Pyogenic granuloma is the first possible differential diagnosis in this patient. You have to remember, it's a very, very common entity. We will discuss about what exactly it is. So this is solitary, friable, red, bleeds, sessile or pedunculated, tender, well localized, tender, soft or firm, and well localized is very important. Well localized, very, very commonly. Skin adnexal tumor, another differential diagnosis. Skin adnexal, you know that, sweat gland, sebaceous gland, subulosebaceous unit, all those things are called as skin adnexa. So tumor arising from these sweat glands, all this adnexa, skin adnexal, the skin adnexal tumor is a different entity. So it should be a differential diagnosis for that. Cutaneous papilloma doesn't look like that, this because it is well localized. Often it will have a pedunculation. Skin color is more darker. So people still keep it as a differential diagnosis. But these two are very, very important differential diagnosis. So pyogenic granuloma, first diagnosis. This is the next differential. This is the next differential diagnosis. This is the amelanotic melanoma. So another thing, but it's unlikely, but you have to keep in mind. So these four conditions always you have to keep in mind when the patient presents with the swelling like this, remember. So what is pyogenic granuloma? It's a localized proliferation of new capillaries, fibroblasts, which are intermingled along with the RBCs and few WBCs. It is common in females. This patient also, female patient, this is common in females as I already told. It is also called as granuloma pyogenicum, another name. So this same name it is. So it can occur in skin and mucous membrane. It occurs spontaneously sometimes. Minor trauma may be there, infection focus may be there. They are not very sure. So it is whether it is infective origin or neoplastic origin is a debate. Presently it is considered as a neoplastic origin. That's why they say many times it is a misnomer. So Staphylococcus aureus infection can cause. This bacteria itself can cause pyogenic granuloma, or once it forms, it may get infected by Staphylococcus aureus. Both way it is possible, remember. So this is the probably current pathological terminology. This is a lobular capillary hemangioma. Even though clinically we call it as a pyogenic granuloma or granuloma pyogenicum, which is very well accepted clinically. But pathological name is different. Actual name is lobular capillary hemangioma. That's what you have to remember. How to treat pyogenic granuloma? It is treated by surgery. Treatment is surgery under local anesthesia with the excision. Usually you will put elliptical incision around the root of the swelling after giving local anesthesia, xylocaine 2%. Then you excise it. Then once you excise it, use bipolar or monopolar cautery to fulgurate the bleeder. And once you do that, close the skin using usually non-absorbable suture material like ethylon, 3-0-ethylon or 2-0-ethylon depending on the location situation and status of the swelling, whether it's infected or not. And surgeon's choice, use non-absorbable suture material and then remove it after 7 to 10 days. So other treatment other than surgical exercise which you can try is application of salt, petroleum jelly, Vaseline, you know, it's called as petroleum jelly. And imiquimab is quite good, 5% imiquimab. Many skin conditions, imiquimab is very useful. Remember, here timolol 0.5% gel, silver nitrate, trichloroacetic acid locally or other therapies. So these are the different non-surgical treatment which can be tried initially for pyogenic granuloma. So antibiotics, short course maybe for 5 to 7 days. Cryotherapy, laser excision, cauterization, all these things are tried, but ideal treatment is surgical excision to cure the condition. So once excised, it should be sent for biopsy. It's very, very important. I said differential diagnosis, maybe skin adnexal tumor, Maybe rarely, it may sometimes, because we don't know, clinical features might sometimes overlap. So always send it for biopsy, don't throw it, it's very, very essential, very important. And note, important thing, pyogenic granuloma may be misnomer. There is no pus, even though it is called a pyogenic, and it's not granuloma. Actually, it is a neovascularization. It is a lobular capillary hemangioma. So it can be called as a misnomer, remember. No pus, it's not a granuloma, it is a benign, currently considered as a benign tumor, even though we call it a pyogenic granuloma, granuloma pyogenicum, Staphylococcus aureus is the cause, all those things. Clinically it is accepted, but pathologically it is a benign tumor as such. So you can go through my book, clinical book, SRB's Clinical Method of Surgery 4th edition, or my clinical book, SRB Manual of Surgery current edition, and operative surgery also we can go through that. All these things will give a detailed description of pyogenic granuloma, operative procedure, technique, everything. So students, I hope you understood this brief case discussion, which is a very, very common short case kept, very, very common disease which we come across in our surgical, day-to-day surgical practice as such. Thank you very much.